Dr. Ankur Shah, whose talk is titled Overcoming Barriers to Therapeutic Innovation in Kidney Disease. Dr. Shah is an assistant professor of medicine and interim director for clinical research and medical director for peritoneal dialysis in the DaVita North Providence program in the Division of Kidney Disease and Hypertension at the Warren Alpert Medical School, Brown University. He's an expert in home dialysis and the intersection of planetary health and kidney disease, areas in which he is well published and has lectured both nationally and internationally. His work is supported by the NIGMS, AHRQ, Advanced CTR, and the SURDNA Foundation and the Rhode Island Foundation. He's a member of the ASN Policy and Advocacy Committee, and he always has something interesting to say. Thanks very much, Dr. Shah, for joining us today.
Thank you. First off, thank you for the opportunity to speak today. I very much appreciate this from this invitation. And so the talk today is going to focus on what I think is a critical but overlooked issue in kidney disease care, which is how the structure of our payment systems has stifled therapeutic innovation. And we'll kind of go through the root of the problem, how current policies discourage progress, and what reforms could reverse that. And we're really going to be focused on dialysis here because, excitingly, we actually have pretty great innovation in CKD. So we're really focused on dialysis. These are my disclosures, nothing relevant to today. And so the challenge here is that kidney disease is, of course, one of the most costly and deadly chronic conditions that you can have, but it remains among one of the least innovative spaces in modern medicine. And this isn't for a lack of need or complexity. There's a structural failure in how we incentivize care. If you look at 5-year survival for in-center hemodialysis, it still hovers around 43%, and it hasn't changed very appreciably since 2010. And I'm sure many in the audience are familiar with these numbers, but per year Medicare fee-for-service spending for bennies with ESRD is nearly $100,000 for in-center hemo and $85,000 for PD. And in addition to mortality and cost, there is tremendous morbidity. Our patients experience a myriad of symptoms every day. They experience nausea, vomiting, cramping, itching, dry skin, restless legs, and more. Way more. And so this isn't living. This is a lot of our patients are dialyzing to, or living to dialyze, not really dialyzing to live. And this also isn't improving very much. And there are reasons that this isn't improving. Let's start with research. NIH funding for kidney disease is among the lowest relative to disease burden, and we saw from Dan's talk that this is even more threatened now. And despite accounting for more than 7% of Medicare spending, kidney disease research gets a fraction of what's spent on cancer, HIV, cardiovascular disease. That means less basic discoveries, fewer early phase trial, and ultimately fewer commercial candidates for innovation. And you could argue the NIH spending on the right may be a little bit denominator biased. If you were to remove some of those elderly CKD 3A patients, the NIH spending per patient will go up. But if you look at the budget from a few years ago, it is still far below our contemporary illnesses. And, this isn't just a public funding issue. Private investment follows incentives as well. And we just don't have a strong business case. If you compare us to oncology, we are in the middle at 409, and then look at where oncology, neurology, endocrine metabolic are. VC funding in dialysis and in kidney disease is very low, and really where that VC infusion has been is really in the space of care coordination, less than in the space of therapeutics. And it makes sense, because why are VC firms going to invest in dialysis if they don't see a reimbursement or a return? And those things lead to this innovation gap. So first off, I want to just shout out Suzanne Watnick, because this slide is motivated by a paper that she wrote. And so if you look at new FDA approvals by year, the little orange sliver that doesn't even appear in 2022 are drugs related to dialysis. A little bit of context, the green or the blue here is malignancy related drugs, and the gray is all FDA approvals. So we have very few therapeutics, and even the ones that we do get, they don't diffuse into practice very well. And so we get a system that really is heavily reliant on decades old technology. And so when I say we have an innovation gap, I want to first point out what innovation can look like, because this is innovation in diabetes and chronic kidney disease. When I graduated fellowship, it wasn't too hard to do clinic. I made sure my patients were all on RAS inhibition. And then from there, I was kind of in an evidence-free space. Nowadays, they need to be on RAS inhibition, SGLT2 inhibition. You could debate nonsteroidal versus steroidal mineralocorticoid inhibition, GLP-1 receptor antagonists, and we're already looking to the future for even more growth. We have had breakthrough therapies that fundamentally change how we approach CKD progression. If you're a glomerular disease specialist, The number of therapeutics in your armamentarium is exploding by the day. I just have to say the word IGA, and I think everyone in the audience can think of innovation when you think of IGA. But then if I say dialysis, this is what innovation looks like in dialysis. And I want to be fair, we do have some technical progress. We do have new home machines. We do have some new medications. We have things that can impact infection-related morbidity. We have patient-centered new anemia drugs. We have patient-centered drugs for symptoms like itching. But they're not getting to broad adoption because the economics don't work. And providers aren't incentivized to adopt new modalities if there's no payment for the cost of doing so. And so innovation has become a liability instead of an asset. And I just want to show you what I mean when I say innovation becomes a liability instead of an asset. So when I say that we haven't seen adoption, the y-axis that I'm showing you here is not a fraction. It's a fractional percent. So despite FDA approval in 2021 and evidence from phase 3 trials, difelikefalin, which hopefully I said that right. I always question whether or not I should include this slide because I don't know if I want to say difelikefalin in front of a large audience. But by the end of 2022, more than a year post-approval, 0.32% of Medicare fee-for-service bennies on hemo were receiving it. It's 1 in 300 patients. And that's pretty glacial when you consider that uremic pruritus affects up to 85% of dialysis patients. There's a big gap between 0.3% and 85%. Which is at least more than zero. Daprodustat didn't even make it onto the market. It was voluntarily withdrawn, and from the GSK press release, they specified that the reason for withdrawal was fiscal, not efficacy nor safety. So why? Why do we have this innovation gap? And so I would like to posit that the reason why we have this innovation gap is the bundle. And so the bundle, as far as a little bit of history, it is how we get paid right now as physicians and as units. And so this system, I would say really the prior payment system in 1983 started our path to the bundle. So in 1983, we had a composite per session rate that reimbursed dialysis facilities for outpatient costs, and then some of the routinely provided meds, labs, and supplies. But by 2006, the separately billable drugs and biologics had actually grown to be 40% of the total expenditure for ESRD care. And so in 2011, we got this new bundle, this case mix adjusted bundled payment system for dialysis facilities that aimed to bring everything into the bundle. And by statute, what they did is they used the lowest utilization cost data from 2007 to 2009. And we've really been locked into this methodology since 2011. And so I would argue that the issue with innovation is that we are practicing 2011 medicine in 2025. And I think that I will say 2011 medicine was better than 2008 medicine. So I think early on the bundle was effective, but we are stuck in it. And so why did we do this? So there were goals of the bundle, of course. They wanted to contain costs. They wanted to align incentives for modality choice. They wanted to encourage efficiency. They wanted to simplify billing. And so the bundle was designed to do these things. And I want to say in some senses it did succeed. It's just we didn't really anticipate what would come after it succeeded. But, let's talk about the wins. So the first few years of the bundle did bring success stories. ESA use fell drastically. So what you're seeing here is from 420,000 patients receiving HD between January in 2009 and June of 2011. This graph is receipt of ESAs in people with hematocrit greater than 36. And the receipt of ESAs in people with a hematocrit greater than 36 fell by 7 to 9 percentage points. And you can see that sharp inflection point of when it happens. You don't need me to do any sort of statistics to tell you that there's a change here, and you can tell exactly when implementation went into place. There was no difference, though, in ESA use in people with a hematocrit threshold of 30 or 33. So the payment reform was really, it worked well. It brought down ESA use in those who may not benefit from it, but it did not bring down ESA use in those who would benefit from it. And there were other benefits from this early as well. There were cost savings. We ended up resulting in about a $25 per session savings in drug spending as we moved to more iron, less ESAs. We moved to less expensive vitamin D substitutes. Peritoneal dialysis has been growing since 2011, and home hemodialysis continued its pre-existing growth trend. But we saw decrease in costs. We saw more conscientious choice in medications. We saw growth in home dialysis. So let's not ignore what the bundle has given us. And the bundle has given us. So what you're looking at here is annual percent change in Medicare ESRD spending. The blue bar is total. The orange bar or yellow bar is cost per patient year. And again, this is another one where I don't need to point out to you where the bundle went into play. You are looking at a very sharp demarcation from left to right here. And ESRD spending had really high growth rates from 05 to 09. You had nearly 10%, or you peaked at over 10% annual interest or increases per patient. Increases were 8% in 06, 8% in 09. And then they moved to near zero or slightly negative growth in the later years. So really a drastic difference. And so the bundle did give us cost containment. But the bundle giveth, the bundle taketh away. So what you have here is mortality by modality from 1985 to 2012. So what you see here is you see this steady decline in mortality amongst all modalities. For ESRD patients, you went from about 240 deaths per 1,000 patient years down to 140 deaths per 1,000 patient years. So you're seeing this really significant improvement in HD, PD overall until 2012. And now let's look at 2009 to 2018. So if you could argue like 2012, 2013 onwards, but from 2013 onwards, that previously declining mortality trend began to plateau. And so we're kind of stuck at 130 to 135 deaths per 1,000 patient years. And for ESRD and dialysis, mortality has leveled off at about 165 to 170 deaths per 1,000 patient years. And this is a big shift. We had huge improvements for 25 years in a row, and what we have now is a plateau. And so the question should become how did the bundle bring us to the plateau? And so I will tell you what I think is the how, and this is just an overview of the elements that we will discuss. So the first thing I want to talk about is the bundle gives us this fixed bundle compensation. So CMS effectively locked in the bundle contents to what was available in 2008 in calculating the base rate that new treatments will fall into, because they use existing categories of dialysis care that were expected to be covered under that preset payment. So they created these broad functional categories for drugs and biologics like anemia management, bone mineral disorder treatments, based on those that were used before 2011. And any new drug that CMS determines fits into one of these categories is not eligible for a payment increase. It's part of routine care. This means that genuinely novel products can be regulatory classified as if they're interchangeable with older treatments, even if they provide new benefits. For example, new anemia medications, new FASN binders can be grouped with older drugs. So that classification hurdle discourages manufacturers from pursuing approvals for innovative products. There's a lack of built-in updates for new therapies, and I will sneak preview that we will talk about the attempts to fix this, but I'm going to keyword and highlight attempts. So the bundled payment system creates a fundamental barrier to innovation by not having clear pathways for integrating novel drugs or devices. CMS kind of assumed that the mix of services and their costs will remain similar to that 07 to 09 baseline. And that rigidity means that even if the FDA approves a breakthrough dialysis therapy, there's no PPS framework that automatically provides a mechanism to adjust payments for it. Ultimately, it fits into that stagnant payment bundle, and that creates barriers to adoption. And CMS did try to fix this, or attempt to fix this, with Band-Aid solutions, which is what I would call them, which would be TDAPA for new drugs and TPNIES for qualifying devices. You'll hear about them in a bit, but just the sneak preview on them is that the relief they provide is temporary and limited. So aside from the one-time inclusion of oral-only meds into the bundle and the example that Dan had shown earlier with cinacalcet, or with calcimimetics, we haven't really seen a lot of movement here. And so we also have thin margins and an underpriced base rate. Dan showed you the thin margins before. CMS used the lowest per patient cost year from 2007 to 2009, and then cut off 2% by statute to produce that baseline rate. So taking the lowest payment over 2 years, then a 2% haircut. And since then, we've got annual updates that go through market basket updates, but they've been minimal and they tend to be smaller than what other Medicare payment systems offer. So in effect, we started out low and we failed to keep pace with the cost of labor, supplies, and general inflation. And you saw the MedPAC advisory for 2025. For 2024, they estimated that dialysis facility Medicare margins would be roughly 0%, so that we will be breaking even on Medicare dialysis treatments. And that's a problem because they also showed that many of the smaller facilities and independent ones will have margins below zero. And so operating under such tight economics, it leaves you with very little room to absorb the cost of new innovations. If you aren't being offered additional incentives for innovations and you don't have any margin, where do the innovations fall into? And so a novel therapy or device, it comes actually at an added expense with a flat payment. It's actually discouraged instead of encouraged. You get a financial penalty. And so that discourages early adoption. And the reason you get a financial penalty is because we don't have a financial incentive. So under a bundled payment, once providers find a cost-effective regimen to deliver standard dialysis, the best financial strategy is to stick with what is cost-effective. Investing in a new drug or technology offers no immediate financial reward. It actually probably reduces profitability. And so unlike fee-for-service systems, the bundle, it's a closed budget. And without external funding, improvements cost us money. And so when you're a VC or an industry investment group, you notice this constrained environment and you do not invest into it. And there actually was a letter from a group of bipartisan US reps last year that noted that Medicare's role has diminished Medicare's role in how it pays for kidney drugs, devices, and medical products has diminished interest amongst investors and companies in developing new kidney treatments. So our legislators have even identified that this is limiting innovation. And, capital flows. If capital is not flowing to us, it is flowing elsewhere. And so there were 2 attempted solutions. So there are TDAPA and TIPNIs. You'll hear more about these later in the day as well. But I think that the first thing we have to do is at least that there was this acknowledgement that there is a need to encourage innovation. So these 2 temporary carve-outs, TDAPA and TIPNIs, offer time-limited supplemental payouts, initially 2 years, now extended beyond that for qualifying new products, trying to bridge that gap, but the regulatory limitations are pretty drastic. There's only been 1 device ever approved for TIPNIs, and TDAPA just brings way too much uncertainty with it. And so that uncertainty with that payment cliff after 2 to 5 years makes it so that facilities are, hesitant to adopt new therapeutics. You saw the adoption of difelikefalin earlier. And so I think that's a really important example. So what do we do now? The first thing I want to say is that, as we showed you before, payment reform can spark change. Payment reform in the adoption of the bundle did spark change. We saw a shift in these lines, and if we can go from A to B, I would like to argue that we can go back from B to A. And the other thing I want to tell you is it's important we do this now because we're on the precipice of actual improvement in dialysis and maybe even an off-ramp from dialysis. So we're at an exciting time where hemodiafiltration is going to be rolling out in the United States soon. And maybe even more excitingly, we're looking at a world that could potentially make dialysis not the default to kidney failure treatment. And we need to make sure that at this fork in the road that we are ready to adopt innovation to make dialysis better, or even better than that, make dialysis a thing of the past. So how do we do that? There's 2 options. We can try to fix the system, or we can build a new system. I think what's clear, though, is that the system needs changing. And so I'm going to just start a discussion. I'm going to describe a few options that could either patchwork the system, or at the end, I'm not going to talk about too much about what a whole new system could look like, because that is a discussion that goes beyond one speaker. But I just want to talk a little bit about what our options can look like. And so our first option would be to adjust the bundle to reward new innovations. And so what that could look like is a permanent add-on mechanism for new therapies. There was legislation proposed in 2024, the Chronic Kidney Disease Improvement in Research and Treatment Act, that would require that Medicare add a new drug into the base rate after its TDAPA period in a non-budget neutral way. That would mean that if the drug was in an existing category, CMS would increase the bundle payment by the actual average cost rather than by assuming that it would be covered by the old rate. That type of policy would ensure that, once a drug is proven and needed, facilities have sustained funding to use it. Similarly, stakeholders have suggested parallel approaches for new devices. If a new machine or supply is demonstrably better, its cost should be built into the payment system going forward. So that would require us to permanently carve out funds for innovation, but doing that will remove the uncertainty that currently scares off adoption. We need to look at that base rate. We began our base rate by looking at the lowest rate amongst 3 years and then cutting it further. And we also have failed with the update mechanism. So broader economic adjustments here might be something that we can put onto the table as well. With that evidence that facilities are at zero or negative margin for their fee-for-service, you can argue very clearly that the bundle is underfunded. And there is a history of a one-time forecast error adjustment being given for underfunded bundles. This was done for nursing homes in the early 2000s. So we can address these inadequate payment rates by advocating for that. It's a technical one-time fix to adjust us back for all of that underestimation and cost updates. We can try to tie the bundle updates to a more realistic inflation index, or allow add-on adjustments for labor costs and other expenses that have spiked. So we can try to shore up that base payment rate and say, maybe we focus on innovation, or maybe if we shore up that base payment rate, we improve margin to allow for margin for innovation. So when clinics, aren't on the financial brink, they can take on a calculated risk. And we can align incentives with other settings. So we can look at what Medicare does outside of kidney disease. And this is a little bit outside of the box, given I just showed you some of the wins and losses related bundling, but we can unbundle. So maybe the solution is to look at what oncology does. What oncology does is when they have new drugs that are administered in clinic, they're paid separately under Part B, typically at drug cost plus 6%, and their oral drugs are covered under Part D. We don't want to go right back to the problems that the bundle fixed, but we may be able to find a happy medium between what the bundle fixed and what it later gave us. And so for ESRD, maybe a potential reform is to allow pass-through payments for truly novel therapies, the way the hospital outpatient PPS does and has pass-through payments for new drugs. We may want to consider getting some drug classes outside of the bundle unless and until a safe mechanism to include them is crafted. So potentially removing or delaying certain items from the bundle, which I know sounds a little crazy because the bundle was done to get around issues related to exactly this. But maybe we've seen one extreme, we've seen the other extreme, and maybe where we need to do is go back to the middle. So that's another option. Or we can start from scratch. The world is our oyster, sort of. But maybe the solution is to say that we need to move off of the bundle altogether and look to a whole new system. But I think what I want to tell you is that whatever the solution is, there needs to be a path forward. We have a core problem. Innovation has been stifled. We have a challenge here. We have an innovation gap. We have stagnant mortality rates. We have lower NIH funding. We have less industry. We have less VC. We have less approvals. And I think that the barrier here is the bundle, because if you look at all of these trends, you see that inflection point right at the introduction of the bundle. And now is the time to look forward, because now is the time of excitement. We've all been to Kidney Week in years past when the late-breaking clinical trials sometimes we're not so clinical. Now we have multiple sessions and it is standing room only. And we need those multiple sessions, that standing room only, to have more expansion into end-stage kidney disease. And I will say, I think it would be great if end-stage kidney disease becomes less of an issue. A much better solution is to prevent dialysis than to fix dialysis. But there's a lot of people currently on dialysis who need it fixed. And as best we can do about preventing dialysis, we will still end up with people on dialysis. So I think the ideal path forward is one that would make me a little bit irrelevant. I would love to be innovated out of my job as someone who spends a lot of time in kidney failure. But until we get there, we need to continue to make life better for the people who have kidney failure. And so with that, I want to say thank you to the American Society of Nephrology, to Ali and Sumit for the invitation, and to a few people who have been great mentors and advisors to me. I've learned absolute tons from Suzanne and Roz, and then my mentors locally, Susie, Joel, and Amal.
Thanks so much. That's really, again, another thought-provoking talk. It's been a really good morning so far. I want to kind of ask you about, you're framing it kind of all from a US market forces perspective, but obviously any innovation could come from anywhere else and also affects everywhere else as well. And so I know this is a US kind of oriented course, but do you see any kind of important framework we should touch upon in terms of the global dialysis market and how that impacts innovation in the US or vice versa?
So I think that one of the things that we see in largely kind of across healthcare, global healthcare systems, that a lot of the innovation comes from the US. And I think that we're lucky. We have built a very, very robust healthcare research infrastructure. And as we saw, we are currently seeing a lot of impacts to that healthcare research infrastructure. But in building that healthcare research infrastructure, we have become the global kind of like the place for the greatest minds in the world to come to do their science. And so I think that a lot of cutting edge science has come out of the US, and I think it's been a lot of effort that has gotten us there. And so I do think that there may be space, particularly as we see Europe, Canada, China, other countries that are increasing investment into research as the US is decreasing investment, that we may see innovation from other countries that start to pace and or match and pace us. But a lot of implementation in the US requires that things be studied in US patients. So there is a risk that what we will find is not only will be matched, but we will be exceeded and we could fall behind. The question of would Xeno reimbursement fall within the bundle? I really hope not. I think that remains a open question. I think that if the bundle is not greatly improved, everything should be done that it doesn't.
Can I expand on that a little bit? Because it's not just Xeno, which I think we all anticipate will be very, very expensive, but other kind of just upstream, kind of very promising solutions like gene editing therapies for monogenic kidney diseases, which again would be predicted to be very expensive by some estimates in the multiple millions of dollars per therapy. How do you see kind of like the cost structure of kidney disease care from CKD, and this might be too big of a question, but from CKD to ESRD as a whole spectrum changing, or do you kind of still imagine that the ESRD and pre-ESRD payments will kind of have to remain separate for it to make sense?
So I think that that's a great question. I think it's something for the nephrology community to come together to discuss whether or not we want CKD and ESKD to be within the same system or in separate systems. There's benefits to each model. I think that if we move CKD and ESKD closer together, then we can bring more primacy to CKD care. I think that a lot of nephrology is focused on ESKD care, and I think that if we can bring that together, we can kind of elevate and highlight CKD care. That said, you are correct that we also risk taking the mistakes we've made in ESKD care and applying it to CKD care. So I think that I would love to see a nephrology space where CKD retakes its primacy, but I don't want to see that happen with us then taking our prior mistakes and applying it there.
Thanks so much. That brings us to the end of our slot for you. Thanks so much. That was really, really a fascinating talk, and I think gives us a lot to think about in terms of how we might change the system going forward to improve innovation in this space. Thank you.
Thank you.